Thank you.
So essentially, this is a relatively young guy. He had a traumatic event. So essentially, he was moving furniture, had a bungee cord that kind of snapped and hit his left eye. He kind of lost vision for a little bit, but since then, it's kind of been gradually getting a little bit better. When he was seen, right eye vision was good. Left eye was a little bit reduced, but he pinholed back to normal, and pressure looked good. And then nothing really major as far as medical or surgical history. So then we'll go right into the first image. Yes, Sarah, if you
Okay.
want.
So this is a color fundus photo of the right eye. Media looks clear. Cup to disc looks maybe like a 0.2, 0.3, sharp margins, looks pink. Going to the vessels, they look pretty normal, I would say. The macula looks pretty normal, I would say. Looks like a normal right color fundus photo of the right eye.
And then let's see.
There's some nice.
Yeah.
And this is the left. Sorry, go ahead.
So it's the color fundus photo of the left eye. Media looks clear. Cup to disc, maybe 0.2, 0.3. Just sharp margins. It looks pretty good. Moving on to the vessels, they look pretty good to me. Within the macula, has like a sheen because he's pretty young, I would say. Um, it looks pretty okay to me. Pretty normal. Maybe some AV nicking in the inferior arcade.
So then I think there's a go ahead, sorry.
Okay, this is still color fundus photo, but more peripheral of the left eye. More nasal. Not sure how to describe that. There's like a paler area, the nasal periphery, maybe a little bit elevated. Um,
I think there's a more zoomed in. Yeah,
so it's
it's
a more good.
yeah, I thought it was tough to kind of see. I mean, I knew because I knew what the diagnosis was, but kind of like you said, it was kind of whitened a little bit, kind of the opacification of the retina. Um, I think it is flat, but it definitely is kind of tough to see. But I think based on this image and what I know about the diagnosis, it is flat. So, like you said, mainly just the whitening of the retina, kind of in the peripheral aspect, nasally of that eye. That's pretty much the main thing.
Okay.
Awesome. So that was really all we have right now. So
You can see on that image the vessels go over it, right? So the
Yeah.
vessels are not obscured. So it's somewhere in the retina or deep to the retina. Sorry, guys.
so differential.
Would say maybe like maybe a retinal detachment, a melanoma, an amelanotic melanoma maybe, or what else? Maybe an effusion.
Okay. So what were your main history and findings?
He had the trauma.
Oh, go ahead, Sarah. So Sarah, yeah, what's the main history and main finding?
He had a traumatic injury to the left eye. He was 20/50, but pinholed to 20/20. Pressures were good. His vision was lost for about 2 days, but returned.
Okay, and then there's that white thing.
Yep, and then that white thing in the
Okay.
nasal
Perfect.
left eye.
All right, good. All right, and then anybody else want to help out?
So in this setting of trauma, there's characteristic retinal findings we see in trauma. So like commotio, if it were closer to the macula and around the nerve, you could say like pressure, retinopathy. It's pretty diffuse and related to the trauma, so less likely, you could say like maybe white without pressure if there were no history of trauma.
Okay. Then, all right, so what do you got for differential?
Yeah, it's kind of a broad differential, but you guys pretty much listed the important ones. So Commotio, infectious like ARN, something like that, where you have whitening in the periphery, which is not as likely, and then maybe like an artery occlusion, just whitening in the retina, but it's obviously very peripheral, so that's not as likely. Retinal detachment, and then just these are kind of based on the history itself with trauma, like choroidal rupture, and then chorioretinitis, sclerotiria. Again, I didn't actually personally know what that was, but I saw it as a differential for trauma. And just for people who didn't know, which I was part of that group as well, it's essentially where you have a full thickness rupture of the retina and the choroid. So typically you would see like heme, intraretinal hemorrhage, and you could see the bare sclera as well. I think I have a picture of that. So this would be sclerotiria.
Which is confusing. The chorioretinitis is confusing because it's not a chorioretinitis, it's a trauma, but it's just a name. It's like, what do you do?
Mm-hmm.
Yeah. It was a gunshot.
Yeah. Especially having those a gunshot when that.
Oh,
Yeah, I remember you saying that word and I was like, what is that? And I had to look it up.
and then the fractures, like Kim said. So yeah, so this case was a case of Commotio. And I guess just to jump right into kind of what that is, Commotio, we see it a lot on call with traumatic injuries, a traumatic retinopathy that's typically secondary to trauma to the globe. It can be direct or indirect. So if a part of the globe gets hit, that part can develop Commotio, but also the opposite side where the force is transferred can also develop Commotio as well. Like counter coup forces that can cause that. There's kind of varying numbers as far as the prevalence in relation to trauma, but I was seeing maybe about 30% of eye trauma. When I've seen trauma, I don't think I see it as often as that. Like I've probably seen it once or twice for trauma.
It has to be an eye that you can see. You guys see the trauma where the eye just like, oh,
Yeah.
it has to be like this sort of sweet spot where it's an injury enough to damage the eye, but enough to still see them.
Gotcha.
Right.
And then the symptoms are typically kind of just blurry vision. They can have vision loss, maybe a field defect, maybe a scotoma, or like even metamorphopsia has been reported as well. And just a quick touch on kind of the pathophysiology. Essentially, the thought is there's injury to the photoreceptor processes. And the thought behind that is because the rest of the retina is kind of anchored by the macular cells, which are really, really strong. So those processes are kind of not as anchored, so they can get injured more easily. And then I just put a little picture of the layers because I can never see this enough. I actually remember it. So that green cell is that macular cell, and that's anchoring. I learned recently by Dr. Margot, it's a very, very strong cell. So I guess underneath it or above it in this diagram, you have the photoreceptor outer segments that don't have that macular cell, so they can be more prone to injury. And then what happens is you have the deposition of debris of different cell fragments, and that can injure the RPE, and it can also collect in the subretinal space. And they're also saying that the reason that it looks white is because those kind of fragments disperse the light, and that kind of makes it white.
People will see a blind spot.
Yeah.
If they're with it enough to tell you, and it'll go away. And I always wondered if it was just the white blocking, but I guess it's just the photoreceptors are messed up, and they have to recover. I didn't know that's cool. We used to tell people it was like a cake, like the retina's like got layers like a cake. So if you whack it, it like shears. I don't know. It seems to be understandable. Yeah. So I guess if the cake would be the layers would be the macular cells and the other one.
So diagnosis, it's mostly a clinical diagnosis, the history of trauma, and then you'll see kind of a pacification of the retina. You may or may not see some hemorrhages intraretinally, and then maybe some mottling of the RPE. So just a couple more pictures of, like different varieties of Commotio. So this one's a pretty severe one. You can actually see some hemorrhages in the periphery as well.
When it's in the macula, is it called Berlin's edema still? Did you find
It's
that?
on iWiki, yeah, that's
Okay, all right.
Berlin's edema,
It's
yeah.
the same exact thing, but it's in the.
And then just another one where it kind of whitens out the area in the macula or near the fovea, can kind of get like a pseudo cherry red spot, like in this picture. And then this is just one where it's very diffuse on the periphery.
It's interesting. The pseudo cherry red, that suggests it's not the photoreceptors, right? Or is it just the macular pigment? Can you go back to that picture? Maybe it's just the pigment blocking. All right. Okay.
And then you can also see some changes on OCT. Typically, the most common one is that you can see hyper-reflectivity of the ellipsoid zone, and I'll show some pictures there. In more severe cases, you can see that the other layers intraretinally can also be disturbed as well. So just some, it's a small picture, but again, just a quick review as far as what those layers are. So the ellipsoid, otherwise known as like the IS-OS junction, that's where it's the photoreceptors, but there's a lot of mitochondria concentrated in that area. So that's what it kind of lights up because of that. And then the interdigitation zone, which is important in Commotio kind of pathology as well, is where those photoreceptors kind of meet with the RPE. So those layers are commonly affected, and I'll show on the OCT, those are the kind of corresponding layers that we'll talk about. So ellipsoid zone, that's that layer that's really important. It's that white line right there. And it's really important as far as visual acuity. If that's affected, it can really affect visual acuity. And then this interdigitation zone is that line. My understanding is sometimes it's typically harder to see than this. This is like a really good picture. So then I'll go more into the grades in a later slide, but essentially in this one, you can see a little bit more hyperreflectivity, I guess, if you kind of convince yourself of the ellipsoid zone. And then in these ones, essentially, if you just kind of have more severe interruption of the different intraretinal layers, you can kind of increase in grade. I'll talk about the grades. It's kind of just one paper that published a potential grading system. And as far as management, usually management is very mostly observational. Obviously, the important part is when you see Commotio, there's probably a very intense trauma, so it's good to do a thorough slit lamp exam just to make sure there's no like lymphedema, like iridodialysis or mid-heme, anything like that. Most cases, as far as the Commotio itself, resolve just by observation within 4 weeks. I think clinically the whitening starts to resolve after about 1 week. And as far as symptoms, visual acuity can improve for up to 6 months. Sometimes it takes that long. It's important to do serial eye exams because there can be complications. I think the most common one is you can develop a macular hole after Commotio, so that's important to look out for. And then as far as the prognosis, usually it is pretty good, but there's been kind of studies as far as what can kind of dictate that. There was one like publication where they developed a grading system depending on how extensive the OCT findings were. And the worse the grade, the worse the prognosis. And then also whether the macula is involved or not is also pretty important. I was seeing that if the macula is involved, there's about like a 25% chance that the end visual acuity will be below 20/30. But if it's extramacular, then typically it's just about like 3 to 5% where it's less than 20/30 in the end. So then just to go back to the OCT findings. So kind of that grading system, increased reflectivity, and then essentially the other grades are just more and more involvement of the different layers, as you can kind of see here. So that's pretty much all there is to it. Just some big takeaways. Essentially, Commotio is kind of a whitening of the retina after trauma. You can see intraretinal hemorrhages occasionally, and it's also important to know that You can have it in the area of trauma or kind of opposite to that. OCT, you can see some findings that we already talked about, and it's important to do serial eye exams just to make sure they don't develop a macular hole or any like detachments or anything like that. And prognosis is good, but you can kind of triage it or predict it based on how much involvement they have on the OCT.
Code purple 9C2.
Questions about all that?
Code purple 9 Charlie 2.
And that's something you'll see a lot. I mean, you guys must see it constantly in the ER.
Is it possible to get an OCT, say, of a peripheral lesion? Because
Yes.
as Albert said, the 1 week, it shouldn't be white anymore, but you should still see the intraretinal fluid color.
If it's, this one would be hard to get. This one's kind of far out, but I'm sure there's OCTs of peripheral. I've not read up on them lately.
I have another question.
Sure.
So for prognosis, so if it's not involving the macula, almost all.
Oh yeah, it should be like 100% good, as long as they don't get a macular hole or something.
But if it's involving the macula, what's the percentage of like going back to baseline vision?
Oh,
Is it
without
almost
percent.
all, or?
It said, it was just from iWiki, it said 26% would typically have a visual acuity worse than 20/30.
Okay,
But I guess
so like 80% go back to
it should at least
Okay.
be better than 20/30, yeah.
Yeah, and you see that all the time. It's very common.